So, right, what I'm going to talk about now is organs and systems affected by long COVID, or rather in long COVID. So basically, it's all these. So there's not much in the body there that's not on the list, is there? Or if you prefer things in diagrammatic form, we've got this. And that one just reminds you that the ACE2 receptor, which of course allows the virus entry into the cell, is found in all these organs and systems. There are a few scanning studies which you can look at there for the prevalence of organ involvement. But I want to make a few points here. So first of all, here's an international survey. The mean number of body systems affected in long COVID patients was 9. Now, when you look at that list I showed you, first of all, there weren't many more than 9 anyway. So the mean number affected was 9. So that means that some patients had more body systems affected than 9. And surprise, surprise, no correlation between the patient's symptoms and scan findings. This isn't always the case, but when it is, it's a bit worrying. So we'll look at the lungs, first of all. So here are the symptoms that we're fairly familiar with, I think. The prevalence, 76% of hospitalized COVID-19 patients were still experiencing breathing problems after 6 months. That's a bit sad, I must say. So this is a kind of lung damage which you can see in long COVID. So if you're not clear on pulmonary fibrosis, you can read about it here. Ground glass opacity is something that crops up a lot in the studies and reports. And actually, this is what it looks like. It's the speckles. So that's what somebody means about ground glass opacity. And it really just helps to inhibit the breathing again. There are lots of anomalies in scanning studies. So you can read about those here. And then a lot of patients are still suffering from hypoxia. 2-month follow-up, 6% of patients were still on supplemental oxygen. This is not good. Predictors of pulmonary dysfunction. Well, urea, which is a test of renal function, proved to be a good predictor of the presence of CT abnormalities in the lungs at 3 months. It's quite interesting. And the measurement of D-dimer, which looks at coagulation, this predicted impaired diffusion defect. And those with subsequent lung fibrosis had higher levels of C-reactive protein and interleukin-6, which are both biomarkers for inflammation. Cardiovascular system, if you like diagrams, there's another one. So just a summary, COVID-19 can either induce new cardiac pathology or it can exacerbate pre-existing cardiovascular disease. The symptoms in long COVID may show no relationship at all to COVID-19 severity. We're seeing this all the time. There's an increased risk of major cardiovascular events up to at least 5 months after infection, and risk of death is really high within the first month. And the biomarkers, again, elevated inflammation and clotting up to 4 months, possibly beyond. Main symptoms and developments, you can read about it here. Prevalence and duration. So here's a UK study. 3 times higher risk of developing heart failure, myocardial infarction, stroke, and arrhythmia at 5 months. And beyond the first 30 days, you've got increased risk of cardiovascular disease for at least a year. And the risk was there even among those who were not hospitalized, but the risk increased with the degree of severity of COVID-19. Arrhythmia, if you're not clear about that, look at it there. Vascular problems, I'll be saying more about that later. Thromboembolic events, so there's a rate of venous thromboembolism up to 2.6% at 1 to 2 months. And mortality. So here's a Polish study, post-discharge mortality rate of patients with cardiovascular comorbidities was 42%, not that far off 50%. Imaging studies show inflammation, 2 to 3 months, ongoing myocardial inflammation in 60% of patients. If you're not clear on myocardial inflammation, pericardial also, you can read about it here. Prevalence, myocarditis in 26% of patients, pericarditis in 3%, and myopericarditis in 11%. Cardiac abnormalities on MRI and other imaging. And the biomarkers again, so 2 months after hospital discharge, 30% of patients had persistently elevated D-dimer, indicating coagulation problems, and 10% have raised levels of CRP, so inflammation. I realize that you're not going to be seeing many pulmonary and cardiovascular disease patients, although Dr. Trefzer certainly did. But nevertheless, I think it's important that you know just what can go wrong so that you understand if these patients come to you afterwards and say, this is what happened to me. I know you'll be interested in the gut. So there are gut symptoms in long COVID as well, and microbiome alterations. So we've got a very specific composition of the microbiota, which is, it's like a COVID-19 profile, which unless you've got people who understand the gut, like all of you, will probably persist well after COVID-19 has resolved and you're into long COVID with gut problems. Acute kidney injury and renal replacement therapy. Here we are. So acute kidney injury affects 37% of hospital patients. They're not going to get better in a hurry. Some of them require renal replacement therapy. So they've got decreased estimated glomerular filtration rate at 35% still, 6 months at 6-month follow-up. So they've still got problems then, and 1.4% of patients experience renal failure in long COVID. The liver, good news is liver enzymes had generally normalized at 2 months. But on the other hand, an MRI scan was still showing fibroinflammation in 10% of patients. Pancreatic injury, here's low-risk young patients for a change, 4 to 5 months after infection, 17% showed mild pancreatic impairment, and another study showing long COVID patients with pancreatitis. Spleen, also problems there. Skin manifestations, yes, you can see this better in pictures. So there we are, that's what it looks like. Musculoskeletal problems, myalgias and arthralgias, common. And of course, anybody who's been hospitalized for any length of time is going to have sarcopenia. The endocrine system, if you like diagrams, there's not that much in the studies on the endocrine system, and what there is are mostly about thyroid and diabetes, or pancreas rather. So let's have a look at thyroid. So 3 months, most abnormal thyroid function tests have been resolved, and thyroid dysfunction was rare. So we're all right then. No, we're not really, as Dr. Trefzer explained. And I'm sure some of the other practitioners will do the same. Of course, it depends what thyroid tests you're doing. If they're the standard GP ones, they're not going to actually tell you much. Diabetes, mentioned that before, possibility of new onset as well as exacerbation. Principal neurological symptoms and conditions, you can have all of these. Prevalence, there are a huge number of studies on this, of which I've just given you a very small sample. Brain scanning studies are quite interesting. So here's a PET scan of long COVID sufferers at least 3 weeks, so fairly early, but still. biomarkers consistent with memory and cognitive impairment and autonomic dysfunction. Oh dear. Significant hypometabolism in the brain. 3 months post-discharge, 55% still complained of neurological symptoms. So risk factors for this, no clear consensus again. Bit on pain there. POTS, if you're not familiar with POTS, this sounds like it's with tachycardia, it sounds like it's a heart problem. It's actually an autonomic nervous system problem, but you can read about it here. A lot of patients seem to have this. This is normal mechanism and management of POTS. And interestingly, it's been suggested that POTS can be an autoimmune condition. So that brings us on to the immune system. So predictors of long COVID. So here's 3 to 4 months after symptom onset. This is actually a very interesting study, which I'm going to return to in my final lecture. So what this shows is that in those patients who had COVID, unequivocally had COVID, they did not suffer long COVID though. And what characterized them was vigorous, coordinated, innate and adaptive immune activation. They had the inflammatory cytokine signaling, they had strong interferon responses, and then the immune and inflammatory response quickly subsided. Great, that's what it's supposed to do. In those who had long COVID, the acute response was characterized by dampened interferon and antiviral responses, coupled with prolonged inflammatory cytokine signaling. So something has gone wrong with the dampening down of all of this. As I said, I'll come back to this in my last lecture. So in long COVID, we can see that it can create autoimmune conditions, inflammatory conditions, and lymphopenia, or sometimes known as lymphocytopenia. So here's a list of autoimmune conditions which have been seen in long COVID. Inflammation, many studies on this. This is again a small sample. Lymphopenia, so here's at 2 months, 7% of long COVID patients had persisting lymphopenia. And at 3 months, it correlated with exertional chest tightness and palpitations. So that's quite interesting. So we've got pulmonary and cardiac symptoms correlating with lymphopenia. So the inflammatory conditions, which you can get with long COVID, is multisystem inflammatory syndrome in children, or MISC. This is actually the American terminology. The UK terminology is pediatric inflammatory multisystem syndrome, but it's so much easier to use the American one because you can just say MISC for children and MISA for adults. You've also got cytokine release syndrome and systemic inflammatory response syndrome, which I'm going to quickly run through now. So MISC is a new syndrome seen for the first time in COVID-19. And there are more than 1,000 cases of children with this globally. And even those who've had mild COVID can experience multisystem inflammatory syndrome with organs and tissues becoming and remaining really badly inflamed. It's fairly similar to features of Kawasaki disease. If you're not sure what that is, see my next slide. And most children with MISC are hospitalized. So if you ever get one sitting in front of you, you suspect they've got MISC, hospital for them. Kawasaki disease, in case you're not clear, MISC and MISA, the signs, symptoms, and tests for it. Risk factors. Right, cytokine release syndrome. This was the next one on the list. So this is what induces the cytokine storm, which is mediated, at least in part, by interleukin-6. And basically, the immune cells generate a positive feedback loop with the cytokines induce more cytokines, which induce more cytokines. That's how that works. Systemic inflammatory response syndrome sounds actually very similar, and it is. This is an exaggerated defense response of the body to infection with a dysregulated cytokine storm causing massive inflammatory cascade, leading to end organ dysfunction and even death. And this is a major contributor to the coagulopathy often seen in COVID-19. Now, when the immune system is working properly, you have a compensatory syndrome. It's all syndromes today. And that's called compensatory anti-inflammatory response syndrome. And this does what it says on the tin, really, and is very useful. It's a counterbalancing compensatory anti-inflammatory response syndrome, principally mediated by transforming growth factor beta, and it leads to immunosuppression, just to dampen down all the cytokines and the other immune activation. So obviously, in any disease, you need a delicate balance between the two. And when the immune system is working properly, that's what you get. When it's not, that's when you have out of control cytokine storm. Mental health symptoms. So this is all the things that you can suffer from with mental health. I'm sure you're not unfamiliar with all of this. Prevalence. So 34% of COVID survivors were diagnosed with a neurological or psychiatric disorder within 6 months. Anxiety was up there at 17%, mood disorders 14%, and they were not related to the severity of the COVID infection. 2 studies found the prevalence of PTSD to be around 30% among hospitalized patients, and one can understand why. But there is a problem here. Here's a 2020 meta-analysis concluded that the prevalence of anxiety and depression in the background population of unknown COVID status during the pandemic was also 30%. And this suggests that the increased incidence of these symptoms could be caused by the indirect effect of the pandemic. And you can see the sense of that. And these are the psychosocial stressors. They do potentially contribute to long COVID, but they also potentially contribute to, well, long lockdown and everything it brought with it. Risk factors. Systematic review found that risk factors for mental health issues were disease severity, duration of symptoms, and, oh dear, being a girl. What can you do? Duration. So, well, the good news is that generally it all improves with time, but not, however, if you've got PTSD necessarily. Studies are divided. Now, I said I was going to come back to the issue of does long COVID really exist? And the issues around mental health are really key for this. Fatigue also to some extent, but it's the mental health issues that are really in the news about long COVID. Does it exist? And incidentally, the people who are saying it doesn't really exist because the background population is the same, it's not doctors saying this, generally speaking, very glad to say. Who it is people who suffered COVID, didn't develop long COVID and said, okay, it's a nonsense, doesn't exist. But unfortunately, they're quite vocal in the media, which is not terribly helpful, really. So let's have a look at the case against. So definitely during the pandemic, there was an increased level of depression and anxiety due to lockdowns, school closures, and other measures. No question about that. If the level was broadly similar, regardless of whether the patient had COVID or not, how can we say it's a long COVID symptom? That's a fairly clear argument. And I will just mention that some people have said, well, we've socially constructed a disease here. Rather, as they said, for chronic fatigue syndrome being yuppie flu back in the 90s, whenever it was. And there's a Lancet article, which unfortunately went on to make headlines in the Daily Mail, saying, well, women are just menopausal. Great. So the case for acceptance of mental health issues in long COVID in no particular order here. And these are my points. They've not necessarily been reflected elsewhere, but here we are. Any study that relies on PCR testing may be unreliable for all the reasons that I gave before. When you're going to have uncertainty about whether your subject is a case or a control, then the results of that study are going to be unreliable. That's PCR testing. Antibodies, as I said before, may not develop. It doesn't in everybody, or they may wane quickly. Had they done T-cell testing, that might have been a bit better, but they didn't, generally speaking. They did antibody testing. Regardless of whether it's long COVID or it isn't, these people are suffering, and you can all help them. I know you can, because it's what you do. They're real people with real suffering, regardless of the actual origin, which is great. So let's help them. But if you're going to say that long COVID mental health issues don't exist, would you also go on to say, well, mental health or long COVID breathlessness doesn't exist? I don't think so. Long COVID new onset diabetes doesn't exist? I don't think so. New onset cardiovascular disease shown up on a scan doesn't exist. So why single out mental health issues to say that doesn't exist when you're not going to do it for anything else? There's no suggestion that there's more cardiovascular disease because of the pandemic measures or breathlessness. It ignores the fact that we've known for ages that viruses can cause fatigue and mental health problems. And there's no suggestion that after these viruses, there has in the background population been a similar level of fatigue and mental health problems. No suggestion at all. And I'll be looking at viruses in my next lecture, other viruses. Others have argued that there's no mechanism for long COVID, so it can't possibly exist. Well, as I'll be showing in my last lecture, I think you'll agree there is a plethora of potential mechanisms. And finally, I had to look up this term medical gaslighting, which comes up in this context a lot. And I discovered it was from an Ingrid Bergman film, which was rather nice. Anyway, I'm sure I hope you never encounter this. Thank you.